Facial injuries can be very serious. Not only are the sense organs, the eyes, ears, nose, and mouth located there, but the nasal and oral passages are also essential for respiration. In addition, the facial area is very vascular and bleeds heavily when injured, requiring prompt and careful assessment and treatment. Finally, but no less important to the patient, are the possible cosmetic effects of serious facial injuries. This program will discuss treatment of various facial injuries to include injuries of the nose, mouth, ears, jaw, and facial bones. Treatment for eye injuries is covered in a separate program. This portion of the program covers injuries to the soft tissues of the scalp and face. Severe trauma to the face can produce profuse bleeding, even if no major blood vessel has been severed. If an artery in the neck area has been severed, bleeding can become fatal if prompt action is not taken. Severe facial trauma may also produce skull fractures and spinal cord injuries. Most soft tissue injuries of the scalp and face are managed as you would any other soft tissue injury. First, do not attempt to clean the surface of a scalp wound. This may cause additional bleeding and further damage if skull fractures are present. Second, do not apply finger pressure to the wound to control bleeding. This can cause further damage if skull or facial fractures are present. Finally, remove objects that are impaled in the cheek only if they penetrate the cheek and exit into the oral cavity. We will discuss these situations in more detail later in the program. First, ensure the use of universal precautions when assessing the casualty. When treating a casualty with facial injuries, you must watch for the following conditions and treat them before treating the facial injury. First, assess the airway problems. Watch for signs of labored breathing, which may indicate airway blockage. Second, if there is serious blood loss, look out for shock. Finally, assume a spinal injury if the patient is unconscious or the mechanism of injury is likely to produce a spinal injury. If you suspect a cervical spine injury, immobilize the head, neck, and spine before positioning the patient for drainage. If bleeding is profuse, suction away blood, mucus, and vomitus. Suctioning should last for no longer than 15 seconds at a time, with supplemental oxygen being delivered between suctioning attempts, if available. Control bleeding by applying a sterile dressing to the wound and holding it in place with gentle pressure. If there is any indication of a skull fracture, do not apply finger pressure. Dressing a wound also prevents further contamination. Do not clean the wound, as this may disturb the clotting process. If facial skin is partially avulsed, return it to its normal position and apply a dressing. Some protocols allow a sterile saline or water wash of the wound before the skin is repositioned. Fully avulsed skin should be wrapped in a dry dressing, covered with plastic, labeled, kept cool, and transported with the patient. If bleeding continues, reinforce the dressing and bandage in place. Adhesive bandages do not work well on scalp wounds, so other methods may be used, such as a self-adherent roller bandage, gauze, or a cravat. To bandage a wound to the front side of the head, secure the dressing with a self-adherent roller bandage or gauze wrapped around the top of the head. For a wound to the top of the scalp, first fold a cravat, lay it over the dressing, and place it at the bridge of the nose and around the base of the skull. Secure the cravat at the base of the skull. Then tuck the apex of the cravat under the tails. And secure the ends on the patient's forehead. Keep the conscious casualty's head and shoulders raised to help control bleeding, as long as the mechanism of injury does not indicate a possible spinal fracture or injury to the chest or abdomen. Never put an unconscious casualty in a head-raised position, even if secured to a long spine board, unless you first position him for drainage. The casualty might vomit and aspirate the vomitus. Also, do not lift or attempt to wrap the head of a casualty who is lying down if a spinal injury is suspected. This will flex the neck and could worsen the injury. Facial fractures present unique problems, depending upon their severity. A mild fracture may not be obvious, so bandage facial injuries carefully and do not put pressure on the injury site. Some signs of facial fractures are swelling, bleeding, irregular bite, loose teeth, inability to talk or swallow, increased salivation, loose or movable sections of the facial bones, facial depressions, or bony protrusions. Swelling, bleeding, and loosened teeth can all cause airway blockage, so be alert for compromised breathing. Since any injury severe enough to cause facial fractures could have damaged the cervical spine, maintain an open airway, provide spinal support, and provide drainage for the patient. Treat for shock and provide oxygen if available. If bleeding must be controlled, do so carefully without putting pressure on the possible fracture sites. Blunt trauma is the cause of most mouth injuries, resulting in lacerations of the lips, inner cheek wall, and tongue, avulsions of the lips and tongue, and damage to the teeth and dental appliances. Assess the patient for an oral injury by searching the mouth with gloved fingers for foreign objects, broken teeth, swollen tongue, blood, mucus, or vomit. Maintain an open airway and proper drainage for the duration of the treatment. For lip or gum lacerations, place a rolled or folded dressing between the lips and gum. If bleeding is profuse, position patient for proper drainage. Monitor the patient closely so he does not swallow the dressing. For a lacerated or avulsed tongue, do not pack the mouth with dressings. Position the patient for drainage. If the tongue is completely avulsed, save and wrap it and transport with the patient. For an avulsed lip, return the flap to its normal position. Control the bleeding with a sterile dressing and direct pressure. Position the patient for drainage. Do not bandage across the mouth. Save, wrap, label, and transport any fully avulsed tissues, keeping them cool. For a lacerated or perforated inner cheek, place rolled dressings between the wound and the teeth and position the patient for drainage. A conscious patient can assist by holding the dressing in place. It is best to leave 3 to 4 inches of the dressing tails outside the mouth to allow for easy removal, and so it is visible to the next care provider. Keep in mind that anything placed inside the patient's mouth can become an airway obstruction. Soft tissue injuries to the mouth often cause problems with teeth and dental appliances. In the case of dislodged teeth, crowns, and bridges, search for and remove these items with gloved hands. There will be bleeding from the socket of a dislodged tooth, so have the patient bite down on a pad of gauze placed over the socket. If the patient is unconscious, you will have to place gauze into the socket. The less you disrupt the injured socket, the better the chance the tooth can be replanted. Do not insert cotton packets into the socket. Wrap the dislodged tooth in moist dressings and transport with the patient. The tooth can also be kept moist by placing it in saline or milk. Do not rub the tooth to clean it. This can destroy microscopic structures needed to replant the tooth. Inform receiving staff that you have the tooth. The sooner it is replanted, the better the chance of success. Ideally, the procedure should be done within 30 minutes. Remove dislodged or broken dental appliances with gloved hands. Transport any dental appliance you remove, whether it is broken or intact, with the patient. An impaled object which penetrates the cheek wall presents a dangerous situation. The object itself can enter the oral cavity and become an airway obstruction, or the bleeding may become profuse and interfere with breathing or make the casualty nauseated and induce vomiting. Simple external wound care will not stop the flow of blood into the mouth, so special care is needed. First, determine whether the impaled object has perforated the cheek wall by looking inside the mouth with a penlight, or else carefully probing the inside of the cheek with gloved fingers protected with a dressing pad. If the impaled object has not perforated the cheek, leave it in place. Stabilize the object and bandage the wound. Refer to the videotape titled "Treat a Wound with an Impaled Object" for further information. If the object has perforated the cheek wall, carefully remove it by pulling it out in the same direction that it entered the cheek. Do not twist the object. If the object cannot be easily removed, leave it in place and evacuate the patient immediately. Be sure to position the head to allow for drainage. Remember, an object penetrating the cheek wall may also have damaged teeth or dentures, creating the potential for airway obstruction. After removing the object, place rolled gauze between the cheek wall and the teeth. Dress the outside of the wound with a sterile dressing and apply direct hand pressure. Provide oxygen and care for shock. Keep the patient positioned for drainage and suction if necessary. A nasal cannula may need to be applied if continuous suctioning is required. Injuries to the ear are sometimes undetected by the medic or EMT. Often, even if they are detected, they are not taken seriously. It is very important to assess these injuries, since an ear injury may be a sign of a more serious head injury. Also, if the internal structures of the ear are damaged, deafness or serious problems of equilibrium may result. Injuries of the external ear are usually quite obvious, but you will not be able to see if these structures of the middle and inner ear have been damaged. The same signs and symptoms can indicate an injury of the internal ear or an injury to the bones of the skull. The following signs and symptoms may be present with either injury. The patient will complain of internal ear pain, ringing in the ears, dizziness, and excessive wetness inside the ears. There will be clear fluid and or blood coming from the ears, and the patient will have a hard time maintaining balance. Bloody or clear fluids coming from the ear must be considered to be a sign of possible skull fracture. The following procedures should be taken for various ear injuries. Treat a partial or full avulsion of the ear as you would any other avulsion. For abrasions and lacerations, apply a sterile dressing over the wound and bandage in place. If blood or clear fluids are draining from the ears, apply loose, sterile dressings and bandage in place. Do not pack the external ear canal. Do not probe into the ears for foreign objects. Prevent the patient from hitting the side of his head in an attempt to free objects from the ear. Again, if you observe any signs or symptoms of middle or inner ear injury, treat the patient as if a skull fracture is present. Both the external and internal structures of the nose can be easily injured when struck by a blunt object. Since inhaling is done primarily through the nose, airway obstruction can occur when there is a nasal injury. Even though the mouth may be clear, blood and mucus from a nasal injury may flow into the throat and cause major airway obstruction. Injuries to the nose can also be associated with injuries to other parts of the face, back of the head, and cervical spine. When you assess a casualty for nasal injury, remember there may also be damage to the nasal septum, nasal bones, upper or lower jaw, back of head, or cervical spine. Care provided for nasal injuries is usually conservative, with the purpose being to maintain an open airway, control bleeding, and position the patient for drainage. Treat avulsions as you would any other avulsion injury. For abrasions, lacerations, and punctures, control bleeding and apply a sterile dressing. For a foreign object in the nose which cannot be seen, have the patient gently blow the nose, keeping both nostrils open. Do not allow the patient to blow forcefully and do not probe for the object. If the object cannot be dislodged by gentle blowing, transport the patient to a medical facility. Do not allow the patient to blow the nose if there is bleeding from the nostrils or the patient has recently controlled a nosebleed. If an object is protruding from the nose, do not pull it free, as it may have penetrated the septum or tissues high in the nose. Transport the patient without disturbing the object. The medical term for nosebleed is epistaxis. There are many causes of epistaxis, some very minor, but the basic treatment is the same. If there are no signs or symptoms of skull fracture, have the patient sit down and lean forward to provide better drainage. If this is not practical, have the patient lie down with the head slightly elevated or turned to one side. There are 3 prescribed methods for controlling a nosebleed. First, have the patient pinch the nostril shut to control bleeding. If the patient is unable to do this, you can do it or have a bystander with gloved hand do it. Pressure should be applied for at least 5 minutes. Another method is to place gauze pads under the patient's upper lip and hold them in place until the bleeding is controlled. The third method is to place a cold pack on the bridge of the patient's nose. The cold will help constrict the blood vessels. No matter which method you use, do not pack the patient's nostrils. If there is clear fluid or a mixture of blood and clear fluid draining from the nose or ears, the patient probably has a skull fracture. In this case, do not pinch the nostrils shut or attempt to stop the flow in any way. Do not blindly pass a suction catheter or nasal airway into the patient's nose. Trauma-induced nosebleeds can range from minor to very serious. Often, the patient swallows blood and vomitus. Prolonged, profuse nasal bleeding can even result in shock. Keep in mind that nosebleeds are not always a result of injury. High blood pressure, infections, and excessive sneezing can all cause nosebleeds. If a patient has a bleeding disorder, the bleeding can be difficult to control, no matter what the cause. When transporting a patient with minor facial injuries, no special positioning is required. Since respiratory difficulty is often associated with more severe facial injuries, transport the patient in the lateral recumbent position. If there is any indication of spinal injury, completely immobilize the patient using a cervical collar and long spine board. The board can be propped on its side to aid drainage. Continuous suctioning may be required. Monitor the patient and be alert for airway problems. When the facial soft tissues are injured, there may be underlying bone fractures. When transporting the patient, be very careful not to put unnecessary pressure on the injury sites. Injuries to the face can be life-threatening and disabling without proper treatment. Your prompt and efficient treatment of facial injuries can prevent complications, as well as reduce the possibility of disfigurement for the patient.